I would like to talk about cancer predisposition. I mean, I think most of us know the risk factors and where we think about cancer predisposition, and it's often associated with a younger age than normally anticipated for the particular cancer type. And also if a patient has multiple primary tumors or the tumors are multifocal or bilateral. Then there can be tumor markers, like with the Lynch syndrome, where there are specific proteins, but it can also be a high tumor mutation burden. It can be homolog recombination deficiency. It can be the family history of the patient, where it kind of indicates there is a risk of a hereditary predisposition. It can also be toxicity, where the patient reacts unusual to the treatment, and also dysmorphism. So even though these are older, we still have to think about the dysmorphism. And I think in our center, we had a woman around 20 with cervix cancer. And it was first when she reacted really strongly to the chemotherapy with toxicity that it was commented upon that she was really small and had microcephaly. And it was actually the toxicity which led to genetic evaluation, and she had the Bloom syndrome. But so nobody kind of found that in childhood, and even though she'd had all the infections and also had learning difficulties, it was when she got toxicity to a cervix cancer that she was diagnosed with Bloom syndrome. So that's just saying that you still have to think about is something small for or odd in some way, then think about cancer predisposition. So in Towling group have, and I know this is a busy slide and it's difficult to see, but they kind of divided the genes within the AU group, and they divided it within within different organic systems, and then the different cancer types, and then the genes you have to think about. And it's just really busy, this slide, and it's just to illustrate there are actually quite a few cancer-prone syndromes, and it is not easy to be a physician and navigate in all these different types of cancer. And within childhood cancer, there is, for instance, the MyPOC tool. So this does not really exist for adult cancer in the same way. Then there have been different groups have tried to look in then what is the frequency of cancer predisposition syndrome in this cohort. And the different publications end up with a frequency between 10 to 35%. And I think this also illustrates that it's very different from tumor type to tumor type. So some have a very high frequency and some have a very low frequency. So it's really to know the different tumors, to know if there's a high probability of cancer predisposition. Genetic screening, then why should we do it? Is there any point? I mean, the person have already got the cancer. So one is of course treatment adaptation. We know some of these syndromes are very prone to develop toxicities. Another reason could be that the patient have increased risk of a secondary cancer, and surveillance should be implemented. And then also genetic counseling. We have more and more people that opt to get pre-genetic testing, like egg sorting. And also it's also very important for the family members to try and identify other persons also with increased risk of cancer. But even though perhaps the relatives don't have increased risk, it's actually also very important to identify this and then have the family members for genetic counseling, because they are really scared of developing cancer. So if you kind of find the genetic etiology and then find that other family members don't have the increased risk, this is actually a really important message, because a lot of people with a lot of cancer in their family, they have the thought it's not when, it's not if, it's when they develop cancer. So it's actually something that they think about daily. So I think it's just really important to have this in perspective. And then how to do it. And then it's increasingly important that we think about pre-test genetic counseling and then also post-test counseling, because as we have more and more markers within the tumor analysis and also more and more tumor mutation analysis, actually quite a few get more or less a genetic diagnosis just by tumor testing, where they never really have had any information that this potentially could be hereditary or something they should think about. So it's just really important that you think in your guidelines how to make certain that they actually know this. So it's just not something routinely done, because it's very much important to know this. And then who should we test? And there's quite different recommendations in different countries. And I think this is also based on the availability of genetic testing, how many genetic counselors there are and genetic doctors, and also the cost of testing. And there's quite a different approach. So some countries recommend that all with cancer below the age of 50 should be tested, and that's really, really liberal, and that's not most places. This is recommended. And it is not recommended in Denmark either. So there's a German group who's tried to look into what are the different cancer types and when should we, like per standard, recommend genetic testing. And it's quite an extensive chart. And there's also important here to see there are differences in different populations with some of them. For instance, as you can see, basal cell carcinomas, it says whenever a person have had more than 5. If I did that in Denmark, it would be a ridiculous number of people who should be testing for Golden syndrome. So seeing this to dermatologists in Denmark, they would just say, I mean, we are too light skinned, have too much sun. So this does not make sense in Denmark, but it could make sense in other countries. So they are definitely individual, something you have to think about. And then there's also really like some of the large groups with colon cancer is everybody below the age of 50, and breast cancers, that would be mostly below the age of around 40, and then also those that are what we used to call triple negative breast cancer, but it's quite diverse. Most cancer syndrome in this population would be autosomally dominantly inherited. So here we have a father with a genetic predisposition, and then the risk is 50% to the children, and it's if this allele has been passed on, and it's got nothing to do with sex. And this is quite a misconception for a lot of people, that they actually think it's sex determined, a lot of those autosomally dominantly inherited, but they're definitely not. And why do they then have an increased risk? And that's kind of the Knudsen hypothesis, that whoever carries a germline alteration on one allele is just a higher probability of something happening to the other allele, where it then causes tumor development, than if it's a person without genetic predisposition, where it has to be the same cell, will first have an alteration in one allele and then the other. This is too simplified. Actually, it's mostly just retinoblastoma, where it's enough with 2 alterations in the RB1 gene to develop tumors. For most other tumors, it's like around 3 genetic genes or other events that has to happen before we see the tumor development. Some of these syndromes are more prone to de novo variants, and that's the case where we don't find anything in the parents and we find it in a child, and nothing then in the siblings either. And some of these syndromes, that would be Pacheco syndromes, have a high de novo. Familial polyposis have like 20%, and the Framini syndrome has also 20%, and the poly, it's a rare gene for childhood cancer, but it has definitely been reported 2 or 3 times with de novo variants in children with cancer. Another concept, which is quite important, that is the mosaicism, and that is where the event does not happen within the egg or the sperm cell, but some of the early cells, and then it's every cell that are derivative from that cell that has the pathogenic variant, and then causes this mosaicism, which is the level is different in different tissue, and it's quite difficult, and this is something we often see in NF1 and NF2, but definitely we can also see mosaicism in TP53. So it's just, if sometimes it's not possible to find a pathogenic variant in the blood, but for instance, NF1 or NF2, then we have two different tumors with then genetic test, and then if you find the same pathogenic variant in two tumors, then we know that this could be a person who's mosaic for the variant. And then you probably all know this, but just really important to distinguish between somatic and germline variants. So germline variants inherited are in all cells, whereas somatic variants are only in the tumors. And it's because at genetic department, we actually get quite a few referrals because of something found in a tumor, not at all found in the person. And that causes distress for the patient. So just have this distinguished. For breast cancer, the BRCA1 and BRCA2 is 3% of women with breast cancer who have a BRCA1 or BRCA2 alteration. 20% of women with a breast cancer, they are ER negative and normal 2 expression. So what we previously called a triple negative or basal type breast cancer, and around 10 to 17 of ovarian cancer. In the background population is 3 out of 1,000 who has a BRCA1 or BRCA2. There are very many different penetrants, but this is a publication from 2017, in which is relevant here is that is the penetrance at not the proband, but people who have gone to surveillance. And you can see it starts around 25 years old, where the risk of breast cancer starts, and ovarian cancer with BRCA1 is around 35 and BRCA2 around 50, that you see an increased risk of ovarian cancer. And both of them have around 70% risk of breast cancer and 50 and 17% risk of ovarian cancer. We know breast cancer susceptibility, we have the high penetrant genes, and then there's the moderate penetrant genes, and then we have a lot of SNPs, and 313 SNPs. We know kind of creates a polygenic risk score. And this is something which is actually, I think it's breast cancer is the one cancer type where it's established you can use this polygenic risk scores now, at least a Caucasian, where they have been validated. And if you have some of these genes, particularly this is a PALB2, which is a quite high penetrant breast cancer gene. So if you have a PALB2 variant and you don't know anything about the polygenic risk score, a woman have around 50% risk of developing breast cancer. But if you have a PALB2 and a very high risk of polygenic risk score, then it increases to about 80%, and a very low, it doesn't decrease very much. But if you have a CHEK2 variant, which is kind of these moderate penetrant breast cancer genes, just having a CHEK2 is just below 30% risk of breast cancer. But having a high polygenic risk score and a CHEK2, then it increases to 60%. And having a low polygenic risk score, then it actually decreases to below the background population's risk of breast cancer. So this is actually something which is more and more clinically implemented, that you also need to add these polygenic risk scores to evaluate cancer risk. So we cannot just use these moderate penetrance genes. The Li-Fraumeni syndrome, it's probably 1 out of 5,000. And I think in most population, we have not identified that many people with the Li-Fraumeni syndrome. So probably there are quite a few out there we do not know about. About 20% are de novo variants, and there are different kind of clinical criteria where you can say it's a classical Li-Fraumeni or devised competent criteria where you also kind of can fulfill them, and then clinical have the Li-Fraumeni syndrome. But in normal practice, it's kind of accepted the Li-Fraumeni syndrome. You do only have that if you have a pathogenic variant in TP53. So we do not use the clinical criteria. We use them to determine who to genetic screen for Li-Fraumeni syndrome, but because it's a very, very extensive surveillance, you really need to have a pathogenic TP53 before you recommend for anybody to have yearly whole body MRIs and yearly MRIs of the cerebrum, and breast cancer prophylaxis surgery, and etc. And it's quite different, the tumor pattern for adults compared to children. So in children, we know we have a quite high frequency adrenocortical carcinoma. This is almost not at all happening in adults. We have quite high occurrence of CNS tumors. It's not like they do not occur in adults, but it's much smaller frequency. And also the leukemia fraction is actually higher in children compared to adults. The large bump here in adults, that's breast cancer. So the moment you are not a child anymore and you're a woman, then it's definitely, you can also see that from the publication of Christian Cuts. These are women and mutation positive with the Li-Fraumeni syndrome and men. And you can see here, this is the breast cancer curve. And we have quite a few of the women with Li-Fraumeni syndrome who opt for risk-reducing mastectomy and reconstruction because of this is something you really can do something about. And apart from that, it's mostly soft tissue tumors you then see in adults, but then you can see this what's called other, which is quite high, which really can be anything at all. So there's just this massive risk of a lot of different cancers where you have to think. And in breast cancer, it's mostly estrogenic positive, and HER2 increased expression breast cancer we see with the Li-Fraumeni syndrome. So that is in particular that you have to think about it in a very young woman with breast cancer. Then there is the DICER1 syndrome, where there have been developed guidelines within the SIO group. And probably know the DICER1 syndrome, where things that are mostly found is multinodular goiter, and apart from that, single cyst in the lung. In the very small children, we have these pleuropulmonoblastomas and cystic nephromas and Wilms tumor, but the moment they are from 15, what we do see is the cervical cancer, where it can be rhabdomyosarcoma of the Broido type, and then also the sertoli cell tumors, and then when they are older, it can be these thyroid cancer. The multinoidal goiter and DICER1, it is quite distinct with a lot of calcification. So actually the risk of thyroid cancer is quite small. So it's really important that DICER1 children are followed in a center familiar with DICER1, or unnecessary thyroidectomy can be performed, because in the normal clinical setting, the endocrinologist would be very concerned of the risk of thyroid cancer, but it's really quite small. So it's important they're not over-treated. And then, of course, there's also the CNS tumors, where it's the different kinds of tumors there. So surveillance-wise, when they are above the age of 15, it's the thyroid examination, and then for the women, an annual ultrasound of the ovaries until the age 40. It's really a syndrome where there's a very low risk of cancer, but above the age of 40. So it's mostly in the very early childhood, and then up to 40. Then there is the hereditary leiomyomatosis and renal cell cancer, which is caused by pathogenic variants in the fumarate hydratase gene. Also a gene where if you have biallelic variants in it, then you have a mitochondrial disease. The heterozygous variants, then you find these cutaneous leiomyomas from the age of 16. It's actually quite painful to have these. The uterine leiomyomas in women from age 20, and that's also really, really painful, and actually affects their life quality quite a lot, because it causes severe bleeding and a lot of pain. So having that and combined with these cutaneous leiomyomas is something where you should think about this hereditary leiomyomatosis and renal cell cancers. And then there is a 15% risk of renal cell cancer, which is papillary type 2, and it's actually been reported also in children from the age of 11. And the cancers are isoechoic. So you cannot use ultrasound, that will not identify them. So they need to do MRI scans yearly. They're very aggressive. So compared to von Hippel-Lindau or the other syndromes with increased risk of renal cell cancer, it's important that these are treated in a very early stage, or they will metastasize and have a really poor prognosis. Within the colorectal cancer, around 80% are sporadic, and 20 to 30 have familial, and 3% of colorectal is the Lenz syndrome. Lenz syndrome is defined by a germline variant and mismatch repair gene, and that can either be a pathogenic variant of MLH1, MSH2, MSH6, or PMH2, or a deletion in the EpCAM, which then affects the expression of MSH2. But it's also been reported with epi mutations causing constitutional methylation in MLH1. So there's actually quite different mechanisms, but it causes the same syndrome. There's around 1 out of 400 in the population. And there's a high risk of colorectal cancer if you're not in surveillance, and then very many have metachronal colorectal cancer, whereas up to a 50% risk of a new colorectal cancer within 10 to 15 years. There's an endometrial cancer, particularly with MHH6 and 2, and not that much with the other genes. And then around 10 to 17% of ovarian cancer risk, depending on the gene. There is this prospective Lenz syndrome database, which is actually something you can access on the internet, where you just put this in, plsd.eu, and then you can put in the organ you're interested in the particular gene, and then the current age and the gender of the person, then you will find the cancer risk. And this is people who go to surveillance, and they still actually have quite a high cancer risk for colorectal cancer. Originally, it was thought that you could prevent all colorectal cancer. Now we think we probably can prevent 2/3 of them, and then the last 1/3 still develop it. So it's like 10 years later than we saw previous. And then there's also these trials with aspirin. The CAP2 trials showed that there were it was people who had aspirin 600 milligrams in 2 years daily, and the long-term follow-up showed that there was a 9% risk of cancer in the treatment group and 50% risk in the placebo group of colorectal cancer. So and right now there's the CAP3 trial, because 600 milligram of aspirin daily is really a high dose. So now there's a titration trial where you try out with 100 and 300 and 600 milligrams to see if this kind of can decrease the risk of cancer within Lenz syndrome. Surveillance are recommended colonoscopies every 2 years from 25 years and a bit later with the other genes, and also gynecological surveillance every 2nd year from age 35, and there's also increased risk of urinary tract tumors and the upper gastrointestinal tumors. And we also have quite a few patients who opt for prenatal diagnosis with the Lenz syndrome. Cervix cancer, it's quite rare with cancer predisposition syndrome, but it's not like it can't happen. And it's particularly with the DICER1, we already talked about that with the embryonal rhabdomyosarcoma, but also with the Petechigas syndrome, which you know from the mucocutaneous pigmentation, which actually kind of tends to fade with age. So you can see it in childhood, in the oral, but also anal cutaneous, where you can find these pigmentations. There's quite a high risk of very many types of cancer and quite young onset. And in childhood, for the boys, there's the testicular Sertoli cell tumor. And then for the cervix cancer is an adenoma malignum, which is a rare, well-differentiated adenocarcinoma of the uterine cervix. And when you do a pap smear, you do not find this. So the women have symptoms with a lot of vaginal watery discharge, and then they go to the gynecologist, who, if they're not familiar with the Petechigas syndrome, then they will only kind of find that it's normal, and it really has a quite poor long-term survival. So it's just really important to know this about the Petersburg syndrome. If there is a watery vaginal discharge, is something you really should take very seriously. There is a network within the European reference network called Genturis, which is regarding rare cancer syndromes. And it's just a network kind of working to try to facilitate more genetic diagnosis, and then also do a lot of folders and exchange within the countries, how to develop genetic detection, also surveillance and informations. And it's just important to know that a lot of these rare genetic syndromes, there's quite few who's not been diagnosed with them. And it's really important to find them, because it really has an impact on finding tumors in early stage where there's a good prognosis. So just to highlight that this network actually exists. So I think that was what I wanted to say. Are there any questions? Or...